This week on the Backtable Podcast.
Too many trainees get hung up on when you're looking and evaluating a group. I think too many get hung up on, well, what are they currently doing there? Like, oh, I went to see them. Well, all right, how many legs are they doing? Are they doing Y90? Are they not? And I understand why people look at things that way. But I think if you're the type of person and you think you want to go out and grow, with a group and grow a practice like this, whether it be PAD or IO or both, I think the real thing that you should be looking at is the group's mentality, the leadership, the equality structure, how decisions are made, their history of aggressive expansion or not. I think those are the biggest things as a trainee coming out that you want to look at if this is some direction you want to go, because I'm eternally grateful for my group and their support. And I think it's just because I chose the right practice to do this in.
Welcome to the Backtable Podcast, your source for all things interventional and endovascular. You can find all previous episodes of our podcast on iTunes, Spotify, and on backtable.com. Now, a quick word from our sponsor.
Boston Scientific can help you advance, connect, and equip your practice with NextLab. NextLab is a suite of solutions and partnerships tailored to meet the needs of your OBL or cardiovascular ASC. NextLab goes beyond Boston Scientific's medical devices to provide ways to reduce expenses and increase efficiencies in your business, so you can focus on patient care. Whether you have an established lab or are thinking about opening one, Boston Scientific can help. Visit bostonscientific.com/nextlab.
Now, back to the show. I'm your host, Dr. Ally Baheti, coming to you from Tacoma, Washington. And our topic for today is creating an OBL within a DR-IR group. My guests today are Dr. Donald Garbett, interventional radiologist practicing in Eugene, Oregon, and Dr. Nick Petruzzi, director of the Vascular Institute in New Jersey. Don and Nick, thanks for being on the show today.
Thanks for having us.
Yes, thank you for having me.
Okay, I'm so glad that I met both of you in my journey because you both have really interesting stories about developing an IR OBL within your IR-DR group. So could each of you give me a little bit of background about the group that you work at? Don, I'm going to start with you.
Thanks, Ally. So I'm in a group of about 20 radiologists, and 6 of them are IR. I came from a group in Texas where we didn't have, we were just hospitalist IRs. So I was pretty excited to join the group. And I was always I always wanted to have our own outpatient center. And so I spent about 2 years thinking about it and just doing stuff. But within our group, I think we're very business minded, the whole group. We have a few MBAs. So that helps to have people in that mindset within the group. And we're in Eugene, Oregon. We're about maybe 250,000 people for our catchment area. What else? It's a mostly private practice environment out here. So, everybody we work with, almost everybody we work with is private practice, besides cardiology, who is all hospital employed in town.
Okay. Is it a single hospital that you guys work at or multiple hospitals?
Oh, good question. Yeah. So we do IR at 2 hospitals. One's about 400 beds and one's about 100 beds. And we do diagnostic for many other areas in a far catchment area.
Nick, could you tell me a little bit about your group?
Sure. We're based in, as you said, southeastern New Jersey, private practice group. I joined them about 8 years ago. I came in as the 4th IR to the team. The larger group of about, I think back then we had about 40, mid-40s, 40-something radiologists. Again, I was the 4th IR. We provide
It was your
diagnostic.
first group out of fellowship, right?
Yes, yeah,
Was
I came
your first
directly.
practice out of fellowship for you?
Yep, came directly out of fellowship. Kind of knew I wanted to head into private practice, and I saw some good potential with this group and also location fit. So I came there. When I joined originally, really no OBL. There was no OBL and really no IR clinic presence to speak of. We had the group had 12 outpatient imaging centers at that time, and we cover basically 2 hospital campuses, each about 300 to 400 beds at each location.
So how did each of you get interested in the idea of starting an OBL? Did you meet a mentor or did something spark your interest? Don, let's start with you.
when I was working in Texas, I went to interview with the Hamilton Vein Center, which they had at the time. I think they had like between 6 and 10 centers, and got to chat with a couple IRs working at the different centers. At the time, I was just considering, do I want to do what I was doing currently, like the hospitalist thing, or did I want to have an outpatient clinic because we didn't have one? And then just seeing that gig, I was very interested in the model. I hadn't really, at the time, I think it must have been 2015. So I didn't have a lot of perspective on it and didn't really know much about it. But just seeing the model, I was very interested. I liked the idea of being able to follow the patients. I had patients in the hospital who were like, how do I follow up with you? And I can't. I would say I can't. But what we could do is get a CT scan and I'll see you when you have your CT scan. It's terrible. That's where it grew from, I think.
Wow, I love that. Every single IR doctor I know has kind of gone above and beyond to try and see their patients, like at some point in some clinical setting, even if it's not in a clinic, if they really want to build it. And yours was just when they came in for their diagnostic imaging. That's awesome.
Oh, and I got yelled at.
Oh, you got yelled at. You got in trouble.
I got yelled at. I actually got in trouble with administration in Texas. I saw the patient. We had just done like a whole total SFA recan, 3-vessel restoration. And, people had told him he was getting an amputation, the whole thing. So it was like the whole rescue thing.
Yeah.
And he was super grateful. And my prior doctor wasn't taking care of me. We did the whole thing. So I had like a CTA runoff or something. I don't know what he had, like a couple months later. And I saw him. And then the COO of the hospital went and found me shortly after that visit and told me that can never happen again. This is not a clinic. You are not running a clinic. If you would like a clinic, you can rent a space. So that I was like, holy cow. And honestly, that moment I was angry and I was like, how do I fix this? And that kind of, and then I started to hear about people like Michael Cumming and Jerry in Florida. And I think, Nick, did you even have your center open by then in 2015?
That was right when we had just initially opened it. Yep.
Interesting.
Yeah, early
Okay.
2015.
So yeah, I think the thought was spreading around the country, but that's where I came from, I guess, my initial frustration.
Okay, Nick, tell us about your aha moment of when you wanted to start a clinic.
Yeah, so it's not that dissimilar to Don's, actually. I think it was also born out of frustration a little bit with the sort of hospital practice. But when I came to my group, originally I didn't have these big plans to open an OBL or really had that direction. I just wanted to have a clinic and provide sort of good longitudinal care of PAD, CLI, and patients. So that was really my main focus. When I first came, I started my clinic, which was sort of half IO and half PAD kind of focused, and in PAD, sort of a special interest in CLI. But I was bringing those cases, just like the IO cases, to the hospital, to perform the angiograms there. And I learned pretty quickly when I came right out of fellowship, and I learned pretty quickly that they didn't have a fully stocked lab, at all for these types of, BTK, interventions and such. We had some iliac stents and, maybe some occasional things for SFA, but really nothing you would need, for below the knee, CLI type work. And so I started trying to stock them up, to get the equipment that I needed. And I remember there was it was actually my first specific request. I said, we probably should have CO2. I mean, we didn't have CO2. So I'm like, I hear a lot of these patients have CKD. Like, maybe we should get some CO2. So, and they're like, what's that? I think the CO2 Mander or the Commander, I don't know how you're supposed to say it, but
yes,
that had,
I call it the CO2 Mander also.
CO2 Mander.
I also don't know how do you say it, Don? Do you call it the Commander?
I don't have it.
You don't have it? Oh, that's great. You got to get it.
Yeah.
This episode is not sponsored by the CO2 Mander.
Yeah. Exactly. So I said, oh, this is really handy because, I didn't know much about the big tanks and stuff. And so I found this had just come out. So, and it's fairly cheap, I didn't think the cost was that prohibitive to it when I looked into it. So I asked the hospital, can we get this? Because I need to be able to, perform CO2 angiography. And they're like, well, you got to go to the value analysis committee. So that was my first, experience with the VAC, the value analysis committee. And they said, well, you got to bring all the data, your articles and whatever you need, to support, the equipment, that you're requesting. So I show up, I'm all organized. I've got my articles from, 1972 showing that, CO2 is a good thing, and contrast nephropathy and all these things. And I'm sitting around I remember it like it was yesterday, and I'm sitting around this boardroom table, and I'm speaking, to a bunch of sort of glazed over looks at me while I'm going through, the rationale for CO2 angiography. And I realized I'm the only physician in the room. I was the only one, with a medical degree, a physician's degree in the room. It was mainly nurses, and there were some couple maybe managers, with probably, like radiologic tech backgrounds and things like that. I didn't think much of it. Honestly, I'm thinking, all right, well, this is fine. I'll finish my my presentation. I'm not sure how much they're following the specifics of what I'm saying, but that's okay. It'll be put through, and it'll be fine.
You kind of thought it was just like a hurdle to jump through that you had to present.
I thought it was like a
they would say,
formality.
okay, yeah, right.
So I go through the whole thing and finish, and I'm like, all right, that's done. And then the next day I get an email, it was denied. So
What?
I said, okay.
Yeah.
And so literally that was like a Friday.
Mhm.
And then that weekend, I started putting together a pro forma. And I said,
love that.
Nice.
I think, because at this point I had a cohort of patients, monthly averages that I'm bringing there. So I had, kind of the patient base that I knew could translate. So I started that weekend. I started working on my pro forma, and after then I was all in. On
Oh my
the
God, I
OBL
love that.
from
So
there on
in
out.
both situations, administrators pissed you guys off enough that you were like, we're doing it. I love that. That's amazing. Don, you've shared stories with me about your interactions with your hospital value-added committee or whatever you call it in Oregon.
Yeah.
And yeah, it's just so frustrating trying to explain stuff to non-doctors, right?
I've had at least 4 presentations for the VAC, AngioVac, Rotarex, and some radial stuff. And every time, you submit stuff and you just expect that they're going to understand, like, that you need this stuff.
Mhm.
And it's just amazing how they just turn it down. And then it turns
Absolutely.
into, I have to do how much work while I'm on vacation to get this stuff into the center where I'm just trying to take care of the patients with, the best
Yeah.
tools. If you're like a mechanic and you need a hammer, you just buy a hammer. Oh, my hammer went bad, or there's a better hammer. I'm going to get the better hammer so I don't hit my hand. But the hospital makes it so difficult.
Yeah, even with pricing, I try to help.
Yeah.
I with help out. Hey, we can probably do better on
Mhm.
these things. Have some vendor relationships and such. They don't. No, don't.
Yeah.
We'll handle the
Oh,
pricing.
we'll pay full price. Don't worry. We'll pay the highest price possible.
Okay.
We don't want free
I
stuff.
love
We don't
hospitals.
want free stuff. Oh, they're going to give you that for free? No. We'll buy it.
Okay, so that was kind of like the initial spark that got you on. So I imagine that the next step was convincing the people around you that it was a good idea. So you guys got to teach
Mm.
me how you did that. Don, let's start with you.
Yeah. So this was kind of awesome. Things just kind of lined up perfectly. So I'd been working on it for like 2 years in the background. I was looking at real estate. I was writing up my pro forma, which I have no business experience prior. So like teaching myself to write a pro forma, I'm sure Nick, you had to learn it too. And then I knew at some point I was going to have to like have a sit down, like Jerry Maguire, sit down in a living room and
Yeah.
get these guys, be king of the living room. And so like just fortuitously, one of the guys in my group said, let's have a vision meeting, right? Like what? Who has a vision meeting in the radiologist group? Nobody cares.
Coming from Oregon, like, did that occur in a forest, like in a drum circle, like around a campfire? Or was that just in a plain old conference room? How do you
I
guys do
assume
your vision
peyote
meetings?
was
Oh, I knew
Was there
peyote was
peyote
coming.
at the meeting?
I knew that was coming. Nice, Nick. You would think. No, so we rented a hotel for the day, and we had like our own conference on a Saturday. We all came in, and they're like our practice coordinator catered. We had catered food and there was coffee, and it was like a whole day just budgeted. Our families knew we were going to be gone for the day. And the whole idea was like, where do we want to be in 10 years? So I had about a month's notice. So I wrote up a PowerPoint and I did, I put in my pro formas. I'd already found all the real estate options, and I had renting versus buying and how much it will cost either way. I had actual locations where we could put our center. I came at it from multiple standpoints. I came at it from difficulties in the hospital, better care for patients, better ability to control our own lives as far as like overnight call, and not having to take care of outpatients at 10 p.m. because the inpatients you still have to do. And I hit it from so many angles. When we finished the PowerPoint, and there was a presentation before mine, don't need to go into it. It was interesting. But after my presentation, all of them just said, okay, when can we do this?
Wow. Yeah.
Nice.
There's immediate buy-in from your group. Wow.
Immediate.
That's awesome.
Well, that was the philosophical buy-in, but
Mhm.
there was definitely the financial buy-in was a whole next step. But
Okay,
luckily
cool.
we
Well,
have like an accountant who worked out the details
yeah.
for us.
Nick, tell me about your story. How'd you get the folks around you to buy in?
It's not that different than Don's, actually, with a few different caveats. But yeah, like I said, I went that weekend. I started putting together a pro forma and running the numbers, mostly just to convince myself, like, is this doable? Is this viable? And I'm looking at it going, yeah. I mean, even with what I'm doing right now, I mean, my practice still had room to grow, but financially, it should make sense. Fortunately, my group, we have, which is part of the reason I joined them, a relatively young leadership, elected positions on there, and they sort of have a history of being aggressive for expansion. So I went to the what we call our executive committee. I went the following week they were meeting, and I took my pro forma there, and I explained my rationale, and I said, here's what I'm already doing, case wise. Here's what I would require, for staffing, equipment. We already had we had the infrastructure in place for the imaging centers. So I figured I could piggyback on that rather than get a new standalone site. We, one of the buildings, we owned the building there. So I just worked in, a rough build out cost to take sort of an old corner of the building we weren't really using. And I went through everything and I showed them the numbers, and then they said, well, are you sure? And it looked really good. And they said, I think your reimbursement numbers are off. And I said, no, this is what, this, this is what this pays. They said, no, you're showing us charges, not payments. I said, I'm not. I was actually showing them this is the payments. So, because they weren't familiar with it, and I don't blame them.
The pushback that I get from that when I show them like collections is they're like, yeah, but how much money do you spend on equipment,
Mhm.
And it's kind of hard to estimate from the PAD cases, like how much you're
True.
going to end up spending.
It is. And you're always going to spend about twice as much as you might think you're going to,
Yeah.
spend, because then you're going to get this
Right.
difficult case, right? And you want to get it done.
Absolutely. Absolutely.
Anyway, so what I did, so I guess I sort of, like Don said, I sort of had their philosophical buy-in, but to get the financial buy-in in order to accomplish it, I sort of needed to, we'll stick with Jerry Maguire theme. I needed to show them the money, and so what I did was we had some of the space, and we had a room we were using for varicose veins at this time. And so and I didn't have a tech, but he was, it was one of our IR techs who was working per diem at the hospital, happened to be a part-time CAT scan tech with us. So I said, all right, you come. So I pulled him, said, we're going to, do some, cases through this. And we had some nurses. So I found out you could demo the C-arms. So that they'll actually bring you C-arms, to demo for 3 or 4 days to evaluate, to buy it. So I found every vendor that exists, for C-arms. so each week in a row was like, I would do, okay, we're demoing GE, this week, and then I give it 2 weeks, and then we're going to demo Zeem this week, and then give it a couple weeks, and so that's what we did, and meanwhile I started doing the first few cases with this, and I spaced it out, and about 3 months later, enough to get sort of Medicare payments back, I had the actual dollars that we're doing, plus I was showing what equipment I was spending. And I went back to them with all that plugged into my pro forma. It was pretty much right around what I had originally planned. And they said, well, you did all your homework, go for it. We're all in. So that's how it started.
That's amazing. That's amazing. Same thing. How did you get your group to have the financial buy-in, Don?
So the financial plan was difficult. We also have imaging centers. So at least we have, a model for outside the hospital. So everybody understands that. Similar to Nick, where he was showing the numbers and they weren't believing it. That's the billing, not the reimbursement. So we have a guy who's what is it called? Revenue cycle manager, who basically that's his whole job. He just tracks the dollars and presents it. So I sat down with him and we did up. Well, so the interesting thing was the pro forma is real, it's real dollars. It was well worked out, but then it's making people believe those numbers are real is a separate step. So I basically used our revenue cycle guy to prove the numbers are real. And then I know it seems complicated, ran it by our accountant who also proved the numbers were real. And then you have enough believability by everybody in the group. Because otherwise it's just your word and numbers on a piece of paper.
Yeah.
So you do need I think if you're doing it yourself, you really do need somebody other than yourself to say, yes, this is real, unfortunately.
Yeah.
Neither of you have really mentioned your other IR partners yet in this stage of development. I noticed that. So from conception to this point, was it all just you two?
Yeah. So to that point, it really was just me. One of my older partners was interested, but he was also reluctant and afraid to rock the boat in the group. More because he's farther along in his career. Things are already good, financially in the group. So it's like, why change things? I think in his mindset. But yeah, I think, I was the youngest partner at the time. I'm trying to think through this live.
No worries. You're like, hey, wait, why was it just me?
Yes.
That's a good point.
Yeah, really.
Wait a second.
It did require, we sat down, I had a lot of sit downs and discussions with my other IR partners. And, I did have to get them on board. It wasn't just like, boom, IR is gung ho and we're going to convince the diagnostics. It was like, I have to get my IRs on board. And then once they're on board, I can get the rest of the group on board. So that was key, because I couldn't have done it, otherwise I would have had to leave the group, without my partners.
How about you, Nick? You had an interesting situation. You were the youngest too. You had a lot of older gentlemen IRs who maybe weren't really familiar with below the knee work. And that's something that you wanted to build in your OBL. How'd you get them on board?
It wasn't very difficult. Fortunately, I was the fourth that came in, and two of the other three guys really jumped on board right away, actually. And again, it was new and different procedures, and a little bit new for the management, the clinical management and follow-up, and fetal work and stuff like that. But fortunately, they are very, very technically skilled. So, if anything, wire catheter skills, at least back then, originally, they've got, years and years of experience to go off of. And I was, the young guy coming out. So honestly, it was a give and take on both ends. I kind of say, this is kind of what we're doing here. This is what, how we're going to cross this and whatever. But, I wasn't afraid also to ask for their help a little bit, with some things. So I was fortunate, really fortunate that the two of them jumped on board really early on, because then we were very cohesive and we had kind of a shared vision of, where we were going to go with it. My clinic and stuff originally was kind of where we started from. So it was me initially, but as soon as we sort of knew we were going the OBL route and expanding, clinic hours and going out and increasing our referrer outreach, they were right there with me. So, and in large part that contributed to our success.
Great. Yeah. Group culture, group support cannot be understated. You have to be in the right group for this to work, right?
Totally.
Mm-hmm.
Okay. So some of the, naysayers might say, well, the hospitals are going to get mad and then they're going to make us lose our contracts. So what do you say? What did you do?
I tell you, for us, that did come up, it was a thing, but the other thing is, we were building and growing IO at the same time. So, honestly, we were bringing more. Yeah, okay, let's put this to rewind. When I came and there was really not much of a clinic, we were never really the provider bringing, referring in to the hospital, right?
Okay.
And then now that we were clinically managing these cases, whether it be IO or PAD, work, we were still, now our name, my name, my partner's name is tied to the procedure that's being ordered, through the hospital. So in a lot of ways, the hospital was viewing us in a much more positive light, because now you could, when we first came, you couldn't find, my partner's names as referrers, right, to the hospital. But the hospitals look at this, on the managerial side of it, and their CFOs and stuff. They look to see, oncologists are huge referrers, right, to the hospital, because they are names tied. They're ordering all this stuff, even when you get down to like procedures and chest ports and biopsies, it's attributed to them, even though us and IRs, are performing it, we're there just to perform the service, in that setting. So, we became a referrer to the hospital. And, by the way, there's still a fair amount of patients that, we, for whatever reason, we were viewing in the hospital setting, as you'll see with PAD patients, coexisting severe cardiac issues,
Sure.
aortic stenosis, things like that. Those are still coming there. So, it was an initial discussion, but I think pretty quickly, when we looked at our volume, and by the way, I made sure that I had that discussion with hospital administrators to show them
Okay.
what I was bringing,
Yeah.
and that also helped, I think.
That's interesting. So you rather than waiting till they found out about it, you were like, hey, we're going to do this. It's going to sound bad, but this is what it's going to mean for you.
Yeah, we even worked it into as our imaging contract with the hospital. We had certain goals,
Okay.
that you're supposed to, like improvement projects per year.
Yeah.
So I actually worked it in pretty early on into to be the improvement project, so that because as part of that project, they were tracking the growth. So then they were excited, to see that.
Oh, that's really great. So you had buy-in from your diagnostic colleagues and from the hospital. Don, anything to add about this subject?
I love that. I just listened to Nick's stuff. I'm taking notes. So we did have a clinic already. The clinic referrer thing, that was an interesting, small, like detail problem that maybe a lot of practices don't know, because we had the same thing. We already had a clinic, except instead of putting my name on procedures that I was taking a patients there for, they were still putting whoever referred the patient to me as the ordering person, even after years of having our own clinic. So only 1 year ago, we changed that so that I'm now the referrer instead of whoever sent me the patient. So that was interesting, and I didn't even realize it was a problem until some point in, somebody pointed it out, and then I was like, wow, that is an issue.
Yeah.
I love the
Yeah, it's a
improvement project
huge change,
idea.
the way the hospitals will see you when your
Yes.
name's tied to all that. Huge.
Yeah, like if it was, if you're a person who does total joints and the primary care doc is the referrer
Right.
for everyone, like
Yeah.
they'd be like, oh, ortho does nothing here.
Yeah.
We're making all this
other
money from the
specialists-
primary care.
See, other
Isn't it-
specialists
isn't it-
know this, but hey, coming from the radiology side, we're used to not having that name on there. So it's a paradigm shift for us.
It's really
It
a
is.
paradigm.
Yeah.
There was one other, what was the question?
I was asking about I was asking in a more eloquent way, how do you not piss off the
Oh,
hospitals
yes.
by creating an OBL? Yeah.
Yes. So I had maybe a little different perspective on it. So I think the main stress point in our hospital was call team use. And, there's been proposals over the years, you're going to give us a second room. We only have one room to do all our cases in. There's CT and ultrasound, but then one angio suite. There's 8 angio suites that are shared by all the different specialists, but we get one.
Mhm.
So, the pressure has been for so long, we can only book 3 outpatients a day because we have that much inpatient work every day. And so we're bottlenecked. That was one of the reasons we wanted another center, but we'd been arguing for another angio suite for years. And, you keep getting promises, and essentially they would do the pro forma and they'd say, oh, well, you're only doing 3 cases a day. And we're like, well, we only have one
Self-fulfilling
room.
prophecy, right?
Yeah.
Yeah.
So it's so weird that I don't know how to, maybe I was bad at explaining it. I don't know why they didn't understand that we really needed a second room.
You just got to be better at the value added committee. I think that's what it sounds like, Don. You got to
Exactly.
step up your game
I
at the
do.
VAC.
No, we had real sit downs with admin, and we'd get the
Yeah.
promise, oh, we're going to do it. And then 4 months would go by and they said, we did our pro forma. And it doesn't work out. So
Oh, wow.
eventually I was like, well, we have two roads forward. We can try to get more angio suite time at the small hospital, or we can get our own angio suite. And that was also one of the stepping points. But where that comes in is the hospital was more concerned about overtime of staff than they were about getting us more time to take care of more patients more efficiently. So when they did come to us, my practice president was the CMO of our current hospital for 2 years. And they did come to him and they said, well, we know you're opening a center. Would you like to do this together? And it just came down to that discussion. Okay, so, we've asked you to get a second angio suite for years. You didn't want to do it. Now you'd like to be involved in our business adventure. What do you bring to the table? And that was the question. Like my practice president just put it back in his lap, and this was the CEO. He just put it back in his lap and said, well, maybe it could work. What would you bring to this business adventure? And he said money, and we don't need it. So if you're just bringing money and we already have money, then you're not bringing anything really to the table other than potentially bureaucracy.
Yeah.
And so we said, no, thanks. Maybe we can revisit this again in a few years.
You hadn't shared that with me yet. That's really interesting.
Yeah. I know that discussion well, Don. So
Yeah.
I think that's similar. And I think you touched on something, though, that's really important. It's like, this was inevitable to happen anyway, because I can't get more than, maybe 2, maybe 3, outpatient cases done in a day. And trust me, it's not because I'm slow at legs. I mean, at this point, I've gotten pretty fast at them. I mean, I'll be in the room, working for cumulative 1.5 to 2 hours or something, for the whole day. And so in order to have sort of a good, in-depth, advanced PAD CLI practice, there's no way they could support the volume anyway at the hospital setting. And I think at this point, they kind of realized that. But again, when you go back to that discussion, it's like, well, what do you bring? Well, we can help. Hey, it's like, well, fortunately for OBL setup and outpatient vascular stuff, like it's not nearly as expensive as it is to put like MRIs in and such. So for a large private imaging group, the numbers actually look like relatively, quote, cheap, right? I mean, it relatively looks cheap compared to them putting in a new office with multiple, 3T MRIs.
That brings us to a really good point. I'm sure at some point during this journey, both of you maybe weren't getting the results you wanted, or didn't see that things were going the way that you wanted them to go, either because of administrative hurdles or group buy-in or whatnot. And you probably thought about going off on your own and doing it by yourself, right? Am I right? Am I thinking
Yep.
right? Okay.
Yes.
So what made you stick with your group?
Yeah, I had that moment, especially early on. I was on a partnership track, and it was early, and I could see kind of the trajectory things were going, and I could see, hey, I think I'm decent. I think I'm pretty decent at this, So I had those moments thinking about that, mainly, a couple years into my partnership track, but early on in the OBL setting. But very early on, it was the rest of my diagnostic partners. They didn't really fully understand, what the difference was between a clinical practice and what I was really doing. And, and they were like, well, your RVUs are lower, and things like this. So that's really where that came from. I started to have some dissatisfaction with that. I actually would find myself coming in at 5 a.m. on my clinic days and reading a few body MRs to pad my RVU numbers, and that didn't last very long until I was pretty, getting burned out by doing this. But fortunately, I brought those concerns, to our committee and my group. Like I said, we have a relatively younger leadership and they're pretty forward thinking. And they were looking at the numbers and they're like, listen, I don't even think we're even calculating your RVs correctly, to be honest, because you're posting these numbers already, and they
Right.
said, you guys are, we know you guys work hard. We see you guys there when we get there and you're still there when we leave. Like you're exempt from this.
Hmm.
It didn't actually take a lot of convincing. Also, I relied on a lot of our, we had a pretty, decent amount of management and expertise, financial, like our CFO, and we have some shared in-house billing coders, and so I found them to be a big resource for a lot of what I was doing, and so it also helped us along, as the practice grew and new opportunities. They became really helpful and indispensable for those type of projects. And I just thought to myself, without having them, could I do it? Yeah, yeah, I could. But long term, it's like, am I going to want to be, on this, 365 days a year, I'm putting in, I still do, but I guess back then I thought that I wouldn't be working as much. But anyway, but it is helpful. I can go away. I have my partners help
Yeah.
cover me. We
Hmm.
have a deeper bench, I guess is what I'm saying,
Sure.
which
Sure.
which and mainly and also part of the reason I joined my group to begin with, and I tell the trainees when they come out, really, if you're looking towards private practice, make sure it's a group where everybody's kind of fair owners, fair
Hmm.
splits. You have some groups where it's like a few old guys, on top, that and there's like different tiers
Mm.
of ownership and
Yeah.
partners and things like that. And I think that's what creates a lot of dissatisfaction and people to leave. And
Sure.
fortunately, my group isn't run that way. So, and they work really hard. And while I'm expanding our OBL and interventional side of the business, they've really aggressively expanded their diagnostic side of the business. So I've never had to look over, be like, oh, you guys are stagnant, when I'm working. So it's all about the group, though.
Oh, absolutely.
Nice.
Don, how about you?
Yeah, I think, we had that vision meeting, but before that meeting, I met with some of the companies that will help you build a lab and get you all set up. So I had those meetings and I kind of had that in my mind as I can do this. I can do that if working within the group doesn't work. And then so I did have that in mind. I knew how I wanted to practice, and I was going to
Yeah.
do it either way. But when the group bought in, I guess that kind of solidified it. But then I'd already had those discussions with some of those companies. And so then when we sat down and had the real discussions of the finances, we were able to bring in those companies actually and have a
Okay.
discussion of, hey, do we want to work with this company that's going to help us build a lab and do the whole thing for us? Or do we want to do it ourselves and try to use our own resources? And that was a good 6-month decision too,
Mm.
which, if you're by
Hmm.
yourself, you can make that decision in a day potentially,
Absolutely.
but it takes longer as a group. But
That's the thing. Yeah. Everything in the group takes longer,
it,
especially if it's a democratic group. Yeah.
it's real, but I think it's certainly a downside, but it can prevent you from making bad mistakes too.
Totally. Yeah. Anything else you wanted to say about that topic? Either of you guys? Anything that I have missed about unforeseen obstacles early on in the development of your OBLs?
I think the billing and coding thing.
Okay.
Yeah.
So and Nick was starting to allude to it with some internal coders that they have in their group. So we have an outside group doing our billing and coding, outside company, and they really lack expertise in procedures. And I had data from like before I joined the group, because as soon as you're a partner, you get access to all of it. And we had it in 2014. They did 154 saphenous vein closures in the clinic before I joined. Maybe 5 of them were billed and collected.
Wow.
So they were paying money to close veins. But when we tried to figure out like what happened, essentially the way it's done is it's so automatic, it's so automated, the billing company,
Yeah.
that they just pull the CPT code off the packs. And if your procedure is not like bundled with the CPT code, it gets
Hmm.
ignored. So simple things like that. And, and for, you do a CT chest abdomen pelvis, it's like 3 CPT codes included, right? But when you
Yeah.
do an SFA recan with tibial atherectomy and an iliac stent, none of that stuff's in the packs. So they were billing it as a diagnostic angio because that's the heading. They were like, aorta runoff, coded,
Nailed it.
done,
Exactly.
$300.
No, that's a great point. I had the same experience very early on, and that even goes into the RVU thing. They're looking, going, well, you did 9 RVUs all day, and I'm like, oh, really? Because I don't understand. Because I did like 3 SFAs and I'm like, I don't think that makes sense because the dollars are really tied to the RVU. It's to some point. So yeah, they were doing the same, billing it as a diagnostic angiogram. So to look at that, because the billing company for radiology groups, it's very straightforward. The CP, I'm getting a CT chest non-contrast, right, and then they bill that CPT. But in interventional and vascular, we bill. There's components, right, to the procedure. And, you might build a diagnostic angio, but you got to get, 37225, you have to get all the other components that you did during the procedure. And so what we found worked best was once I got my EMR, which is a whole nother hurdle. I guess we could talk about that too, because originally my EMR was
This might have to be a 2-part podcast because I feel like we've just scratched the surface about what I wanted to talk to you guys with. But go ahead, please tell me more.
Yeah, I mean, early on, my EMR was PowerScribe. It was into the packs, and it was PowerScribe documenting. So nothing like manually entering patient medications and and vital signs.
Same
While you're dictating. Yeah. So finally, I got an EMR, which helped with that. And when we did that, it had some ability to customize. So we gave the techs the ability to pick the most common codes for these procedures. So that was kind of our first line of defense. Was we finished the procedure, the tech knows what we did. They're going to check the boxes. He or her checks the boxes, and that goes into the encounter. Then we started with that, and then we had the third-party billing company would then bill out from there. We found things were still being missed because maybe if the tech didn't know, that might be supported by my documentation. So then we brought we have some coders, billers in-house. So we put together a little bit of a team. And even on the third-party billing companies end, they have a team that's specific to us. And we found that helped capture pretty much everything. So we've kind of almost like 3 layers of defense.
It's amazing how much we have to put so much work into seeing the patients, doing the clinical workup, doing the prior auth, getting the patient scheduled, doing the case. And then we have to do so much work on the back end to make sure we get paid. It's amazing. And I didn't know anything about that until I got out in practice. I don't know about you guys, but.
Well, and I had no idea. And there's even a difficulty in, you dictate your procedure and you don't realize how important every single word is in that report. I mean, we've done a lot of work with our billers now and coders that now I get back a report from 6 months ago and they're like, well, did you inject the contrast with your catheter tip? Was it from the catheter that you had in the right groin, or was it from the catheter you had from the tibial insertion? And I'll be like, 6 months ago, dude. I don't know.
I don't remember.
But it's, I'll just say angiogram perform from the right leg. I'm not saying which catheter is. I mean, you get the idea.
So true.
So it can even be your error in the coding piece, which is unfortunate.
Okay. We have to wrap up this episode, but I really want to bring you guys back on for part 2 of this because I feel like we just scratched the surface of what we need to talk about here. And I've already learned so much. Could be
a 10-part series, maybe.
10-part series.
Yeah. We'll do EMR next time. That's
it. But I'd love for you guys to tell me where you are right now in your OBL journey. Nick, you're a bit farther along than both of us. So Don, why don't you start with telling us where you're at?
Yeah, so we're in construction. We have a space it's close to 10,000 square feet. It was an old plastic surgery office that we bought. It's been framed and gutted. We're about 2 months from move-in for the clinic, and then from doing cases, we're about 4 months out.
Great. How about you, Nick?
So as we stand today, we have one just led to another. Every time we grew, we'd have people on the outskirts, referrers on the outskirts, wound care saying, and helps with having a marketing team, but, saying, hey, maybe you can help us with these. I'm not so happy with the results we're getting. And then, they become happy with us and they're like, can you come out here? Can you open something here? So we've grown kind of based on that a little bit, just by need, sort of demand. So as we stand today, we have 3 OBLs and we have 11 office locations. We moved into one of our 3 is standalone OBL. It's no longer in this part of the imaging centers. We're actually in the process of building out sort of the original and busiest kind of flagship one as a standalone center. That's hopefully this will be open early 2023,
Okay.
first quarter there. We have 8 IRs now, and we're looking and hiring a 9th now just due to growth. We have 4, actually going on 5 vascular surgeons. So we transitioned into the multi-specialty route a few years back. It just kind of worked out that way. And, between the vascular surgeons and the IRs, we cover 6 different hospitals. And also we cover in some way, shape, or form 3 different wound care centers as well.
I see.
I'm
Yeah.
trained in wound care, as is one of my other IR partners, and a few of the surgeons as well. We have 4 mid-level providers working for a 5th right now. So it's become sort of this behemoth. I don't think it was ever my original plan, but it's I'm very proud of where it's come to be.
That's amazing. That's amazing. Well, thank you both for sharing the origin story with me of how you got to where you are. I'd love to, do another episode where we kind of delve into the nitty gritty, consultants, location, buying or renting, construction stuff, like all of that. But yeah, is there anything that I missed that you think our audience needs to know in the next 2 or 3 months?
No, I think, Nick, you need to run like a program where you just bring
Yeah.
IRs out to learn.
I think one thing I'd like to say, I think for trainees is the advice I give them. If they think this is a route they want to go, and I think it's a great route, and there's a lot of personal and professional satisfaction you can derive from this. I think too many trainees get hung up on when you're looking and evaluating a group. I think too many get hung up on what are they currently doing there? Like, oh, I went to see them. Well, all right, how many legs are they doing? Are they doing Y90? Are they not? And I understand why people look at things that way. But I think if you're the type of person and you think you want to go out and grow, with a group and grow a practice like this, whether it be PAD or IO or both, I think the real thing that you should be looking at is the group's mentality, the leadership, the equality structure, how decisions are made, their history of aggressive expansion or not. I think those are the biggest things as a trainee coming out that you want to look at if this is some direction you want to go, because I'm eternally grateful for my group and their support. And I think it's just because I chose the right practice to do this in. When I left Penn out of fellowship, people were saying, "You're crazy. What are they doing there now?" I'm like, "Well, occasional angiogram." They're like,
Yeah.
my attending said, "You're going to be doing PICC lines and reading mammograms in 6 months." And I was like, "Well,
Yeah.
maybe. I hope not." So anyway, that's one message I think the trainees, who might be listening to this, I think should take away about evaluating potential job opportunities.
Amazing. Well, thank you both for being my guest today on this episode. I've learned quite a bit. Looking forward to learning more from both of you, both personally and professionally.
Thanks so much for having me, Aaron. Appreciate it.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_backtable on Instagram, Twitter, or LinkedIn. Backtable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck, Sabine Dond,
Michael Barraza.
Brian Hartley,
Our audio team lead is Kieran Gannon, with support from
Caleb Hodson,
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz.
Article and transcript support by Taylor Robinson.
And Delaney Aguilar.
Social media and PR by Ann Dang.
And newsletter by Lauren Fang.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening, and see you next week.